Finerenone in congestive heart failure and chronic kidney disease, CKD, incorporating recent developments and landmark trials. Introduction. Welcome to this comprehensive overview of Finerenone, a novel, non-steroidal mineralocorticoid receptor antagonist, MRA, in the treatment of congestive heart failure and chronic kidney disease. Today, we'll be discussing the groundbreaking findings from the FINEARTS-HF, Fidelio DKD, and Figaro DKD trials, as well as the Fidelity pooled analysis. Congestive heart failure and CKD often coexist, forming part of the cardiorenal metabolic syndrome. Patients with these conditions are at significantly higher risk of cardiovascular events and mortality. The renin-angiotensin-aldosterone system, RAS, plays a crucial role in the pathophysiology of both conditions, making it an important therapeutic target. Background on mineralocorticoid receptor antagonists. Mineralocorticoid receptor antagonists have been a cornerstone in the treatment of heart failure and CKD. Traditional steroidal MRAs include spironolactone and eplerenone. Spironolactone, a first-generation MRA, has consistently been associated with elevations in HbA1c in individuals with and without diabetes. This could be due to its relatively non-selective action, leading to an increase in cortisol levels mediated through binding to glucocorticoid receptors. Eplerenone, a second-generation MRA, shows higher selectivity for the mineralocorticoid receptor, but lower potency compared to spironolactone. In the EMPhASIS-HF trial, eplerenone did not reduce the incidence of diabetes in patients with heart failure and reduced ejection fraction. Enter Finerenone, a novel, non-steroidal MRA. It counteracts the pathophysiological effects of mineralocorticoid receptor overactivation on the heart, vasculature, and kidneys. Unlike steroidal MRAs, Finerenone has a more balanced tissue distribution between the heart and kidneys, and a higher selectivity for the mineralocorticoid receptor. Mechanism of action. Finerenone versus steroidal MRAs, 6 minutes. Finerenone's unique mechanism of action sets it apart from steroidal MRAs. 1. Higher selectivity. Finerenone has a higher affinity for the mineralocorticoid receptor compared to spironolactone and eplerenone. 2. Balanced tissue distribution. Finerenone shows equal distribution between the heart and kidney, unlike steroidal MRAs, which accumulate more in the kidneys. 3. Cofactor recruitment. Finerenone acts as an inverse agonist, inhibiting co-regulator recruitment even in the absence of aldosterone. In contrast, steroidal MRAs serve as partial agonists, resulting in some level of co-regulator recruitment at high concentrations. 4. Gene expression profile. Finerenone modulates different transcriptional cofactors and expression inhibition of a different gene profile compared to steroidal MRAs. These unique properties contribute to Finerenone's improved efficacy and reduced risk of hyperkalemia compared to steroidal MRAs. Landmark trials. FINEARTS-HF trial. The FINEARTS-HF trial enrolled 6,001 participants with heart failure with mildly reduced or preserved ejection fraction, HFMREF or HFpEF. Key findings. Finerenone significantly reduced the primary composite outcome of cardiovascular death and total heart failure events. Finerenone reduced the hazard of new-onset diabetes by 24%, HR 0.7, pp 0.06. The effect was consistent across key subgroups, including those with and without pre-diabetes at baseline. Fidelio-DKD trial. Fidelio-DKD enrolled 5,734 patients with CKD and type 2 diabetes. Key findings. Finerenone reduced the risk of CKD progression by 18% and cardiovascular events by 14%. The benefits were consistent across subgroups, including those with and without cardiovascular disease at baseline. Figaro-DKD trial. Figaro-DKD included 7,437 patients with less severe CKD and type 2 diabetes. Key findings. Finerenone reduced the risk of cardiovascular events by 13%. The benefits were driven primarily by a reduction in heart failure hospitalizations. Fidelity pooled analysis. The Fidelity analysis combined data from Fidelio-DKD and Figaro-DKD, including over 13,000 patients. Key findings. Finerenone reduced the risk of cardiovascular events by 14% and kidney failure by 23% across the spectrum of CKD severity in patients with type 2 diabetes. The benefits were consistent, regardless of baseline cardiovascular disease status. Efficacy in heart failure. In FINEARTS-HF, Finerenone demonstrated significant benefits in patients with HF, MR-EF, and SAFE-EF, reduced the primary composite outcome of cardiovascular death and total heart failure events, improved health-related quality of life as measured by the Kansas City Cardiomyopathy Questionnaire, reduced the risk of new-onset diabetes, a significant comorbidity in heart failure patients. Efficacy in chronic kidney disease. The Fidelio-DKD and Figaro-DKD trials demonstrated Finerenone's efficacy across a broad spectrum of CKD severity in patients with type 2 diabetes, reduced the risk of CKD progression, including sustained decline in eGFR and progression to kidney failure, decreased albuminuria, a key marker of kidney damage, provided cardiovascular protection, particularly in reducing heart failure hospitalizations. Safety profile. Finerenone has demonstrated a favorable safety profile compared to steroidal MRAs. Lower risk of hyperkalemia compared to spironolactone. Reduced incidence of gynecomastia and other sex hormone-related side effects. No significant impact on blood pressure or glycemic control. However, regular monitoring of serum potassium levels is still recommended, particularly in patients with reduced kidney function. Clinical implications. The robust evidence from these landmark trials positions Finerenone as a valuable addition to the treatment arsenal for patients with heart failure and CKD. Potential for use in patients with HF-MRF and HF-EF, where treatment options have been limited. Opportunity to slow CKD progression and reduce cardiovascular risk in patients with diabetic kidney disease. Possible role in preventing new-onset diabetes in at-risk populations. Future research directions. While the current evidence is promising, several questions remain. 1. What is the exact mechanism by which Finerenone reduces the risk of new-onset diabetes? 2. How does Finerenone compare to or interact with SGLT2 inhibitors, which have also shown benefits in heart failure and CKD? 3. Could Finerenone be effective in non-diabetic CKD or other cardiorenal conditions? These questions provide exciting avenues for future research in this field. Conclusion. In conclusion, Finerenone represents a significant advancement in the treatment of heart failure and chronic kidney disease. Its unique mechanism of action as a non-steroidal MRA, combined with its favorable efficacy and safety profile, makes it a promising option for patients with cardiorenal metabolic syndrome. As we continue to unravel the complex interplay between heart failure, chronic kidney disease, and diabetes, Finerenone stands out as a therapy that addresses multiple aspects of this syndrome simultaneously. Thank you for your attention to this comprehensive overview of Finerenone in heart failure and its impact on new-onset diabetes. I'd like to extend a warm invitation to all of you to join us at Cardiovascular, taking place in Varanasi on March the 7th, 2025. This conference will feature in-depth discussions on the latest advancements in cardiology and diabetology, including further exploration of the groundbreaking research on Finerenone. We look forward to seeing you there and continuing these important conversations. Key references: 1. Pitt, B. et al., 2021. Cardiovascular events with Finerenone in kidney disease and type 2 diabetes. New England Journal of Medicine, 385-24. pp. 222-52-2263. 2. Bacchus, G.L. et al., 2020. Effect of Finerenone on chronic kidney disease, outcomes in type 2 diabetes. New England Journal of Medicine, 383-23, pp. 2219-2229. 3. Agarwal, R. et al., 2022. Cardiovascular and kidney outcomes with Finerenone in patients with type 2 diabetes and chronic kidney disease, the Fidelity Pooled Analysis. European Heart Journal, 43-6, pp. 474-484.